I'm going to be talking today about one of the areas that I'm working on, thinking more strategically about public health practice, looking to the future, and the opportunities of using healthcare data to reinvent public health practice. And I will explain what I mean by that. So I am going to be starting by talking about data challenges facing public health. Then I will be talking about how there is a new opportunity to help public health through electronic health data. I'll be going through some of the legal and ethical issues, talking about a couple practical considerations, giving an example of a really exciting project that the city is leading, and then finishing up. For the most part, most of the data available to public health is not timely. Vital statistics is really the gold standard, an important gold standard, but it'll come out 6 to 12 months after the end of the year at best. The Behavioral Risk Factor Surveillance Survey, which is a really important survey right now, if you go on the web, you can get 2014 data at the county level, which is not great if you're looking at something that's relatively fast moving. The Medical Expenditure Panel is 2013. The National Survey of Drug Use and Health is 2014. County Health Rankings is a big data set that shows data at the county level, and some of it is quite old, merged over multiple years. When I was in the city, we would always get a call when that report came out, and they'd say, Baltimore's not doing well in county health rankings. What's your answer? And I could always say, oh, that data's old. I told that story on Friday, and a guy raised his hand in the Q&A and said, I'm responsible for county health rankings. Gave me a little bit of a hard time, but it ended with, we know the data's old. America's Health Rankings, the big ranking system for states, also 2-3 years typically, at least, in terms of the data. The second consequence is that it's difficult for public health departments to spot new trends. So I did interesting exercise this weekend. I pulled this graph from the recent CDC publication on overdose, and you see just the huge upswing in heroin-related overdose deaths, and that really started, if you go back, in mid-2010, and you can see it's really picking up in 2011, 2012. The first CDC alert was 2014 on heroin. And the most recent, and that was using data from 2012, right? So you can see they saw the problem in 2014 using data from 2012. And in 2015, they did this release that was as recent as 2013. Well, what's happening right now in heroin is very, very serious. And to be managing it like that with 2 years old data is a huge problem. It basically, the other example I was going to use is the fact that there was just a huge spike in fentanyl that it took a long time for people to get on top of. In that context, I think that there's a huge opportunity which we're just beginning to enter the world of in using electronic data. This is from the Office of the National Coordinator, just showing in hospitals how electronic health records are being adopted. So what is the concept? The concept that I want to talk about is about hospitals primarily, and I'll circle back at the end to non-hospital medical records. But health outcomes appear in hospitals, and population-based health outcomes. So if you're looking for everyone who had a heart attack, they're generally going to the hospital. It's not quite the case everyone with hypertension showing up somewhere in the primary care system. But everyone with a major stroke should be showing up in a hospital. And so in theory, health departments could use those data that are accumulating in the clinical system for timely, frequent, and local data. This map just sort of gives a bit of an example. I have a dream that you can look at healthcare data and really identify asthma factories in the community. What are the places that are generating asthma? Where do we think about where we could look for environmental problems, do pest control, do housing remediation, on the basis of kids constantly getting ER visits or asthma, rather than what we used to do, which was asthma education. How am I going to get a budget for increased asthma education nurses without knowing anything about the number of kids who have asthma, whether the problem's getting better or worse? But now we could say, we know 5 hotspots of asthma in this area of the city, and we want to fund an initiative to do code enforcement and housing remediation or whatever it is that we think is going to have an impact, and then we can see whether we're right. The difference between the previous scenario of let's have an asthma program, let's go around to doctors or do something, and we actually know what the problem is and we can design initiatives, is a night and day difference for public health. Part of the issue is you get into this and you have all these medical records available electronically, we're coming to potentially two different ways of thinking about accessing data. The clinical care framework is about the care team taking care of the patient, having access to data being made available for quality improvement and payment, and that's it. And it's generally a consent-based framework. You give consent, not necessarily for maybe payment and quality improvement, but you're signing it at the beginning, generally, that you're allowing your data to be used for that. Public health gets reportable diseases. So if you have a positive HIV test in Maryland, that is getting reported to the state health department whether you want it or not. And you may well have a public health worker come and try to help you make sure you get connected to the care you need, and make sure that if you want help notifying partners that you can do that. So that's the case for a number of different conditions. So it is not based on a consent framework. It's based on the authority that a health department may have to promote and protect health. And the principles that we came to were, number one, that it has to be justified, that there are obvious privacy issues, right? Just as there are with every use of data, whether it's for syphilis or lead poisoning or any other condition that's tracked by public health. So you have to have good public health practice. And that doesn't mean, that's not a fishing expedition. That's a plan to use the data to improve health. You should limit the use and the collection of identifiable health information to what is actually needed in terms of an organized plan. The use should be governed by legal agreements that require that data not be used for other purposes. The benefits to individuals should be clear. That I think it'd be a very difficult and I think probably wrong position for the health department to be using data in a way that didn't help the individuals whose data it was. There should be transparency of the data use and transparency about the impact on public health. So if we're doing a project to identify the places where asthma is being generated, which I told you was my dream, and there's a clear plan, everybody understands the health department's going to get the data, they're going to do outreach. Well, is it working? People deserve to know that too, not just that you're doing it. And I think that public input is valuable as this field kind of progresses.